faith community help to both get that information out, but even more to help to lower that rate. And we could come back to that at some point, but I think that, given that we've talked about all the spirituality that's in this space, it seems to me that there ought to be some actions that we can take that can push us forward in dealing with this. So next, we have Johnnie Chip Allen, the Office of Health Equality at the Ohio Department of Health, understanding the historical basis and present-day realities of health inequalities.
Good afternoon. Can y'all hear me? A little bit? Okay. First of all, I have to tell you I have a disadvantage when you follow two good speakers. You have to hurry up and try to at least come up to the standards they provided. And I'd like to thank Reverend Randall and also Dr. James. I want to underscore something they said earlier. The work that we're doing and the type of things that we're discussing is very unpopular. And sometimes I would say that the work can be a bit dangerous because when you begin to tell this type of truth, it steps on quite a bit of toes. People don't want to always listen. They don't want to acknowledge it. And they always sometimes don't want to put the resources to very necessary to address these problems. So I just want to thank them for their work and to acknowledge that it takes a collective effort for us to do this work. Next slide. What I want to do today is try to pull together some of the things that Professor Randall and Dr. James talked about in such a way that actually helps you visualize for Colorblind County the types of things they're talking about, but also to try to get many of us to think differently about how we can approach this problem. Next slide. So when we talk about health equity, we had these terms around for a while, and we talked about them all morning. What we're really talking about is the opportunity for everybody in the community to have the best health possible. So when we talk about disparities, we're really talking about the measurable differences. But when we talk about health equity, we want everybody to have the best health possible. Next slide. Just animate. Next slide. Okay. So I grew up in Cleveland. I'm from this area originally. I grew up in the Kinsman area. And so when we talk about health equity, if you look at, for those of you who are from this area, Huff, Beechwood, East Cleveland, West 25th, when we talk about health equity, it means that the individuals who live in those communities would actually have the best health possible. Now, this doesn't mean that people are not going to die. This doesn't mean that people won't get sick. But it means that individuals, that whether or not you live in Huff or whether or not you live in Lyndhurst, you wouldn't expect differences in infant mortality. You wouldn't expect differences in life expectancy. But here's the reality. That between Huff and Lyndhurst, there's a 30-year difference in life expectancy. That's in Colorblind County. Some of my colleagues, Dr. Tony Eisen works with the County Board of Health, and we're actually able to map where individuals live longer. In fact, in this very community that this conference is in, this has one of the best life expectancy rates in the entire county, where we are now. Next slide. Next slide. Okay, so when we talk about health disparities, Dr. James has done a wonderful job talking about infant mortality, but disparities are everywhere. So when we think about these problems, we all know people have heart disease, diabetes, asthma, HIV. And so the question becomes for us, which one do we focus on first? And the reality is we have to focus on all of them because disparities, health disparities, the problems that we're talking about are so common that they're normalized. We don't even sit back sometimes and think about disparities because we know so many people with these type of health issues. Next slide. Okay, so one of the things that I want to do is I want to talk about this in terms of 3 different health conditions. Keep in mind that this problem runs the gamut. Next slide. I'm going to go through some of these. I want to first focus on some of the things that Dr. James talked about, we know we have a serious problem because of infant mortality. Next slide. Next slide. And so one of the things that we talk about as the issue of prematurity is one of the leading causes of infant deaths in the state of Ohio. Next slide. So to look at that, next slide, keep going. One of the things that I do is I use geospatial mapping to be able to help policymakers understand that you just can't talk about the problem in one place. You have to really figure out where these hotspots are. Next slide, keep going. So I'm going to show you a map, next slide. And one of the things is, just go back forward. So I'm going to show you a map of Colorblind County. Here's how you read the map. Anywhere that you see in red, those are census tracts. Why do we use census tracts as opposed to zip code? A census tract has anywhere from 1,500 to 8,000 people with an optimal size of 4,000. And so the reason why we use census geography is because we can compare one area to the other. So if you see a census tract that's colored in red, it means that 23 to 28% of all births in that area between 2010 and 2013 were low birth rates. And then on the bottom of that checkered area, it says worst outcome. 30 to 36% of all births in that area were premature. Next slide. So right off the rip, when you start looking at that in terms of Colorblind County, we see that while we have the issue of low birth weight, in this case low birth weight, and some of those areas that we see in terms of low birth weight also have problems with prematurity. It's not necessarily in the lower part of the county. It's mainly in the north and northeast, all right? Okay, so these are areas that we call hotspots, areas that we really should be focusing on. Next slide. Next slide. So one of the things that happens is geospatial technology allows us to take all those areas that have similar births in terms of what we call hotspots and combine them so that they were one area. So we can then compare that to another standard, let's say the county, to really see how bad the problem is. Next slide. So in this case, if we were to look at the areas that we call hotspots, we would be, and we look at it in terms of racial dynamics, we'd be looking at a population that was 63% African American. If we looked at it in terms of the cool spots and places that have the best birth outcomes, we'll be looking at a population of 86% or 87% white. Now, so when we talk about the issue of the burden of disease, but also who is disproportionately impacted, this tells some of the stories. Next slide. Keep on going. The other thing I want to show in terms of the education rates, if we look at the areas that have the worst birth outcomes, if we look at the percentage of those 25 and over, well, some high school no diploma, it's 18% for that area. But if you look at it in terms of the worst, the places with the best birth outcomes, we'd be looking at only 5% of adults over 25 have some high school no diploma. So when we talk about the issue of infant mortality, and we think of our educational system, education is one of the best predictors of how well you do later on in life. If this holds true, what kind of solutions are we talking about that involve the schools? Next slide. One more. Okay, here's the other piece I want to show you. Areas that have the worst birth outcomes, we talk about these social determinants of health and how it manifests itself in Colorblind County. The areas that have the worst birth outcomes have a 15% unemployment rate versus the places, the cool spots have the best birth outcomes, 5%. So let's just put this into perspective. All of us know that we are just now coming out of the economic crisis, correct? And at the worst part of the economic crisis, the unemployment rate was 8%. So if 8% had people losing their homes, losing jobs, losing resources, if 8% is bad for the United States, what is 15% due to this area that we're talking about? Y'all see the difference? Yeah. We have, so when you compare it this way, and you look at it and you compare it to where these places that have the worst birth outcomes, it makes us think about the issue of economics. I'm going to, next slide. Okay, I want to ask y'all to do something because I know my time is short. Because part of what I want to not just talk about the problem, but how we got here. So, next slide. I want to do a root cause analysis. So root cause analysis is trying to figure out what is the root cause of the problems that you see. Next slide. Keep going. Sit right here. What do you all see right there? Mold, right? We know black mold, right? So we know that that is one of the worst things that we can see within an environment, correct? Okay, so you see something like this, you got serious problems. So if you saw this in your basement or your living space and you wanted to get rid of it, what would you do? Just bleach, right? What else? Huh?
You need some basement work.
Basement? Okay. You all got it. Here's the thing. When we talk about bleach will actually address the problem, but it wouldn't solve the problem. So the bleach problem is a way that we really deal with some of these disparities. Because we deal with the surface issue, but I heard someone over here say, well, you have a basement problem, which means that in order to solve it, we need to get behind that wall. Yeah. Maybe there's a pipe busted, or maybe there are foundation issues. But until we get to what's behind that wall, that mold's going to come back. Particularly, even if we use bleach. Next slide. Okay, so how do things get so bad? Next slide. So one of the things I want to do is highlight the work of my colleagues from OSU, Curran Institute, Jason Reed. They actually took data, historical data from Colorblind County, and we actually tried to link that to the health outcomes that we see. Next slide. Okay, so one of the things that you all may have heard of is redlining. How many of y'all heard of that? Practice in one arm for 40 years. It determined exactly where you could live and in a sense how well you could live. Next slide. So one of the other things that not only did the federal government restrict loans even to people of color who could afford them, but they also actually had covenants that for example, in that time period, you could not buy a home in the area that we're in now. Okay, so what does that mean? Next slide. Keep going. One more time. Okay, so the reason why I wanted to show you that is because based on those housing practices, the suburbs and the areas that we see now were created, but they were created by policy. And so even when you had World War II, you had the gentlemen coming from World War II, and they were able to they had the GI loans. Even if you had a loan, you couldn't buy a house in an area that was relevant to your income because of the color of your skin. And so in the area, for example, for those of you in this area, the Kinsman area, at one point that was a solid Jewish and Italian neighborhood, but then around the 1930s and 40s, you had more African Americans moving in that area. But there are only certain places that they would even be able to get loans. Next slide. This is one of the actual documentation where the areas that are in red, that's what you couldn't get a loan. Okay, next slide. So what I did is this is the redlining map of Colorblind County. And I actually outlined it because I want to show you how that issue in and of itself set us up for the problems that we're seeing today. Next slide. Next slide. Next slide, Frank. Okay, so remember that infant mortality problem I showed you? You got the redlining map on the left, right? Next slide. If you actually kind of put it together, what do you see? High correlation, right? Next slide. One more time. In this case, this is one of my friends at the Ohio Hospital Association. I said, I want you to give me the diagnosis of hypertension through the emergency rooms by zip code. And then I applied that same redlining map. What do you see? And by the way, same pattern. Any places you see in red or yellow, those are the highest percentages of hypertension diagnosed through emergency rooms. Next slide. In this case, this is hypertension and asthma. Same difference. Next slide. One more time. We're trying to be fancy. Okay, so part of the issue is we have a number of different reports and tools to really address this. So we have, unequal treatment. You all seen that, hopefully. It's one of the best documentaries that talks about how do we actually deal with inequalities in healthcare. We have the National Healthcare Disparities Report. We've done a lot of things to try to fix this problem. But the thing that we really need to focus on is how do we really impact the policy that guides where we are now? Because the whole redlining issue went on for 40 years until somebody sued the federal government. Okay, so now we have that much time to catch back up. Next slide. I know I'm out of time, but I just want to say this, and I want to have you think about this, not only relative to thinking differently about the problem, but when we talk about this historical piece, trouble you don't have to find trouble. Trouble will find you, right? So while many of us we had the NAACP and a number of different folks trying to address the redlining policy in which we've changed it now. But discrimination comes in different forms. And so while redlining was the problem back then, subprime loans are the problem now. And so if you don't think that is the case, think about the empty lots that are around the houses or the properties that you used to have and how much value that they've lost. This thing is tied up so intricately into our history that we have to now begin to understand how we got here, but we have to look for forms of the same discrimination that actually got us to where we are now. I'm gonna stop here and ask for questions. Thank you. One question over here.
Is there a hand up there? We'll get you a second.
There's great history and great power to being able to use maps like these in stories. So my question is, how do we make use of this very powerful information and at the same time not lose the fact that when we're looking at infant mortality rates, as I understand the data, a college-educated African-American woman still has a much higher rate than a high school dropout white girl. So how do we make use of this important part of the story and not lose the fact that it's not all about socioeconomic status and socioeconomic history?
Well, I mean, I think it's a matter of attacking the problem on multiple fronts. So maps like these are important, but it's also important for us because I did a 45-minute presentation in 15 minutes. But the other issue is for us to be able to talk about race honestly, and not just talking about race as a social construct, but to talk about structural racism. So, and that's one of the things that when we have these kind of conversations, and I can tell you, even as a person who works at the state level in public health, having these conversations on race and structural racism is very difficult. Because one of the things that they do, they'll say, well, we're doing this cultural competency work, which is very important, but we don't really necessarily think about how how structural racism impacts the decisions that we've made and decisions that we continue to make. We also have to ask the question about what do we invest in? And those hot spots that we show, they're not just hot spots for infant mortality. They're hotspots for HIV and STDs. So the question we have to ask ourselves is, from all of our leadership, what type of, when we talk about new money coming into the state of the community, how are we reinvesting those funds in the areas that we know we have disparities? That's something that we can control at a local level through our county representatives, through code enforcement. There are a number of different things we do. But to answer your question, we have to be able to have a comprehensive conversation about the issue as opposed to piecemealing.
So I want to get this question here, and because of time, and we want to transition, we're going to get one more question. And I'm going to make more comments.
My question is not blaming the victim, but how can we make people be some responsible for their own health? I just see people smoking, young people smoking, and it's all over the world that you don't smoke. Or how do you make them practice safe sex? We have to have some type of responsibility for our own health. How many people do I see walking that are obese? What can we do? I mean, education, and I still see it over and over again.
That's a loaded question, but I'll just give a real quick
It
response.
is.
First thing is, there is, and this is something I have to tell our leadership in state government, is when you start talking, well, it's important for us to take responsibility for our health, but it's also important for us to say what are the conditions that actually allow us to take responsibility for our health. Perfect example, physical activity. We know that we have a very, very serious problem in terms of obesity, high blood pressure, and stroke, and one of the things we tell people is to exercise, right? But what happens if you live in a community, you have pit bulls running around, or it's unsafe? We ask people to eat healthy, but we actually have places that we can identify and counter their food deserts. So it's important for us to have people to take responsibility, but it's also important for us to acknowledge the conditions for them to do that. One last thing, this whole issue of cigarette smoking. Do you know that marketers actually can predict not only what you're going to smoke, what brand you're going to smoke, and exactly how much you're going to smoke 5 years from now? And so part of it is that a lot of things that are done are not done for our benefit. Alcohol sales, now people can, they balance it from it's your right to do something versus is it right for you to do it. And so we have to be able to have those very difficult conversations because they're complex, but it's not just about responsibility, it's about having the conditions for you to take responsibility.
So before we make it, I want to make an announcement. A couple things. Our coordinator, or our person who's leading the way, Mr. Michael Hall, came to tell me that what we're going to do is make sure Ms. Boyce have an opportunity to speak, but we're going to allow her to speak at the lunch time, so everyone will hear her at that time. So she's not going to come up at this moment for her presentation, and she was a bit surprised too, as she, as I made the announcement, I had to deliver the message. She looked at me and was like, "Excuse me." So, but it's a good thing. It's a good thing. So, you know, the one thing I want to kind of part with before we break, and I will also say we're going to be back here in the afternoon, so if there is a need to come back and hear more from the same presenters, please do. Here's a question to the group. My question is, you know, based on everything you've heard, not only from this morning, but now, how many of us in this room feel different? Now, I'm going somewhere with this. So I got hands jumping up immediately. So here's the thing, we can't get everybody. Somebody raise a hand who had their hand up. I just want to know what you feel like. I said, how many in this room feel different? And the hands went up. I didn't. So what did you feel?
I feel about being very educated today, and I've learned a lot of things that I really didn't know. And the organization, including houses like nurses, one of the things I'm going to take back to our next meeting is for us to maybe focus on one project that we might, you know, have some, make some changes.
Okay, thank you. I'm gonna get one other person, and please don't move yet. How do you feel?
I feel very enlightened. I'm a social worker, and the question that I wanted to ask was, what are some concrete or one concrete step that I can give to the patients that we serve that they can do? Just some things that they can do to make their situation better. Just one thing with the infant mortality rate. I was just looking for one thing they can do after we make them aware.
So I'm going to say you at the table with the experts, and I would like if you could respond, if you could pull them aside and get your questions responded to. That's the other thing I want to point out. If you did not have an opportunity for your question to be responded to, you see these individuals, please pull them aside and ask that question and get the necessary information you need to be more impactful. So here's the one thing I'm going to say, and here's a word that I will begin to use, and I hope to hear it. And that is courage. I'm getting the other side that I need to cut. So one of the things I have heard so much about is what we need to do. I've heard Ms. Randall talk about, hey, I was in an oppressive situation, but she kind of said, look, I did what I had to do. And I would also encourage everyone in here who is, you know, above 20 and below 35, to ask yourself, where is your courage while you're working? It is one of the most difficult things to do because you are working within the system and we're concerned about how much money we're going to take home or losing our job. But at some point, we have to ask ourselves, how do we stand for the change that we know needs to happen? And for anyone in this room who's not African American, Gus, Caius, other people in the room, excuse me, I mean to call you out like that, but I will say, and I've said this because, I've worked in this area of racial equity, is where is your courage too? When you're talking to your counterparts or your colleagues and saying, hey, there's an issue here, and when you hear someone say something that's blatantly just way off, and even if they don't know it unintentionally, do we stand up and say, hey, you might want to think about this way, particularly when it's your boss? Because what happens, we become we become authoritative, we become angry black men, or we become rebellious, whether you white, black, or any other color. So take this message with yourselves as you go, and I better stop because then I'm gonna get in trouble. And think about that. Think about the courage that you have, or think about the ways in which you become more strategic in the rooms that you sit in for 40 hours or more a week. Because I know oftentimes you're looking forward to getting home, where you feel like you can be yourselves. And the reality is, if you cannot be yourself in your workplace, if you cannot advocate for yourself and your family in that space, then guess what? You're under stress, no matter what color you are. Food for thought. Thank you.